Hello, I'm Dr. Nirmalya Moulik. I'm a professor of pediatric oncology in Tata Memorial Hospital, Mumbai, India. My talk is on treating pediatric CML in the resource-constrained setting. As we know, CML is a rare disease in children. We currently manage children mostly based on adult data, where it's a very common disease in terms of hematolymphoid cancers that they see. Despite the fact that pediatric CML and adult CML have been shown to be genetically and biologically different in the recent times. Moreover, children who with pediatric CML are exposed to TKIs during a period of active growth and maturation, which predispose them to a distinct set of off-target toxicities of the TKIs, which the adults don't see. Data from low middle-income countries are very scanty on pediatric CML. We just have to rely on a handful of studies with limited number of patients, and many reports that are published are case reports or case series from smaller centers in various resource-constrained hospitals. And of course, like many other diseases, guidelines that are formulated in the high-income countries cannot be imitated because of obvious reasons of lack of infrastructure and facilities, as well as manpower in the low middle-income countries. Now I'll take you through 3 case vignettes just to give you a bird's eye view of all the problems that we face while we manage children with CML in the resource-constrained setting. The first case is a published case from Botswana, wherein a 13-year-old boy presented in August 2017 with high white cell count, low hemoglobin to a local hospital. He was diagnosed with leukemia. The publication doesn't mention what type of leukemia. I would assume it's just a generic diagnosis that was made. The child was started on allopurinol, hydroxyurea, and prednisolone for some cytoreduction, I guess, and was discharged home. Following which the child lost to follow-up, only to present 3 months later with progressive symptoms. This time, in addition to the usual symptoms, he also had intermittent episodes of self-resolved priapism. From the second hospital, he was referred to a regional cancer center where a very high white cell count, low hemoglobin was documented. They did a flow cytometry, a bone marrow, a PCR, and all that, and confirmed the diagnosis to be CML in chronic phase. The child was started with cytoreduction, and imatinib was also subsequently started. The priapism that he had at the time of second presentation took 14 long days to resolve. The second case is from my own hospital. We had a 7-year-old girl who was diagnosed way back in January 2018 with CML in chronic phase, started on imatinib, attained response milestones quite well in time, but then lost to follow-up from February 2020, when was the last follow-up. She came back to us 2.5 years later in May last year with pain and progressive symptoms, having stopped imatinib for 2 years. When asked about the reason for this, they cited COVID lockdown as the plausible explanation behind this lack of compliance and total stoppage of imatinib. Was found to have low hemoglobin, high white cell count, thankfully remained in chronic phase even now. The fish was 70% BCR-ABL1. She was restarted on imatinib within a couple of days from the time she came back to us. Currently, she attained complete hematological response in 4 months and currently remains in partial cytogenetic remission. The third case is again a case from our hospital who presented to us way back in December 2016 with progressive pallor, shortness of breath, abdominal distension, was found to have splenohepatomegaly, low hemoglobin, very high white cell count, and low platelets. Peripheral blood differential showed 75% lymphoid blasts with left shift, which was confirmed in flow cytometry. Fish was positive for BCR-ABL1, and RT-PCR showed P210 transcript. A diagnosis of CML in blast phase was made. The child was managed with initial cytoreductive treatment in the form of low-dose cytarabine and imatinib, following which the child clinically stabilized. At that time, we didn't have second-generation TKIs easily available in our country. Transplant was also not a viable option given the financial condition of the family and the long wait list for transplants at that time. So the child was started on oral chemotherapy with palliative intent, and imatinib was continued. So these three cases, I mean, in my opinion, effectively demonstrates the problems that we see in the low middle income countries when managing children with CML. I mean, broadly summarizing the lessons from these three cases, we have seen diagnostic delay. We have seen that outcome of initial management of complications is often dismal. For example, the first child who presented with priapism, it took 14 long days for the priapism to resolve, which would lead to vital organ permanent loss of vital organ function in many such cases. And of course, management of advanced phases is a big challenge, both in the West as well as in the low middle income countries, more so here because we don't have transplant facilities easily available, and lack of higher generation TKIs is of course another problem when it comes to managing advanced phases. When it comes to chronic phase CML, compliance is of course an issue, and of the multifactorial reasons behind poor compliance, lack of access to treatment, and of course out-of-pocket expenditure, long distances to travel are important issues that we see in these patients. And when following up of these patients, it's very important to do investigations regularly to see how the treatment response has been and to monitor toxicities of imatinib. That also takes a back seat in the resource constraint setting because of lack of multidisciplinary care and difficulty in accessing high-end investigations that come for a cost. Though these anecdotal cases do highlight most important problems that we face in our day-to-day practice, we thought of gaining more insight and solid data on the real issues behind managing pediatric CML in LMIC countries. So we conducted a survey where a pre-tested questionnaire was emailed to 31 physicians treating pediatric CML in 27 low middle income countries. The response rate was good. We got 24 responses from 21 countries. We got responses from Central America, South American countries, African countries, Middle East, Asia, Southeast Asia as well. And of course, we did get some responses from the island countries in the Pacific. So, I mean, the questionnaire elicited various responses. I would just take you through the responses one by one. It was good to see that more than half of the respondents were pediatric hematologist oncologists. However, it was also noteworthy to see that a quarter of the respondents were adult hematologists by profession. And most of the respondents were from high volume centers, as you can see on the second pie diagram. Most of them were practicing in centers that would see more than 100 cases of new pediatric cancer in a year. Now, coming to the number of pediatric CML cases that they saw annually, it wasn't great, with almost more than half of the respondents seeing between 1 to 5 new cases of pediatric CML a year. And most of the respondents hailed from a general or university hospitals with pediatric cancer units in them. How many active cases of pediatric CML are following up in your center? This question elicited variety of response, but most of the respondents saw less than 10 patients, less than 10 active patients at a time in their practice. And coming to diagnosis of CML, while most of the respondents, 58% for that, but to be more specific, would use all the modalities, including clinical, hematological, cytogenetic, and RT-PCR to diagnose CML, but some of them would not be able to use all the modalities because of lack of infrastructure and facilities in their hospital. Coming to the guidelines that they follow to monitor response in such children, most of them, I think nearly 2/3, actually 2/3 of them would follow the ELN and NCCN standard adult guidelines to follow the monitoring, to follow the response. However, a quarter of them would modify these guidelines based on the feasibility. For example, the frequency of doing costly investigations like RQ-PCR and cytogenetics were modified in settings where they are not available easily. Coming to availability of fish, it was very interesting to note about 1/3 of the respondents didn't have access to fish while they diagnosed pediatric CML. And I mean, not surprisingly, many more people would have access to RT-PCR than fish in the current scenario. So if you can see the first pie diagram, only 16% didn't have access to RT-PCR. Rest all had access to RT-PCR, and for that matter, RQ-PCR as well in their setting, whereas cytogenetics was not that commonly available. Not surprisingly, 41% of the respondents didn't have access to kinase domain mutations in their country. Now, when we asked about the goal of treatment of pediatric CML in their practice, I mean, many mentioned major molecular response, which is really quite appreciable. And more than 1/3, of course, mentioned that they target deep molecular response and treatment-free remission in these children. However, I mean, one person mentioned that the target for treatment is complete hematological remission in his or her practice, which is really alarming. And I'm sure this is only because of lack of facilities to investigate, for example, do cytogenetics or PCR in their setting. Regarding switching of TKIs, 16% didn't have any option to switch TKIs, whereas the rest would switch TKIs for standard indications like loss of response, slow response, or intolerance to the first line. The next slide shows quite interesting data, actually. If you see the first bar diagram, 1/4 of the respondents would very commonly see treatment interruption due to lack of access to medicines, which is probably a glaring example of the problems that we face while managing patients in the resource-poor countries. And nearly 1/3 of these respondents would see that their patients were missing or defaulting clinic visits or were non-compliant to medications very often. When it came to transition of care, when these children grow into adulthood, 3/4 of them would transition their care to adult hematologists, but the rest would either leave it to the patient to decide or continue care in the pediatric clinic itself. Regarding funding for treatment and investigations, 1/4 of the respondents said that their patients would have to self-fund their treatment, which actually leads to a lot of issues with compliance and continuation of treatment for a long time. Coming to the first-line TKIs, in the LMIC countries, imatinib was used by 92% of the respondents, where dasatinib was used only by 1 respondent. I mean, not surprisingly, there was one response which said that there was no TKI available in that country. So essentially, management of pediatric CML would be palliative in that case if you don't have TKIs. 83%, I mean, this is quite good that 83% of the respondents said that they have options of using 2nd or 3rd generation TKIs in their country. And more than half of the respondents had access to both generic and innovator brands of TKIs in their countries, which is important when it comes to the cost of generic TKIs, which are much less as compared to the innovator brands. Now we ask them how do they monitor their patients for long-term toxicities of TKI, which is an important aspect when managing pediatric CML. I mean, there's a lot of multidisciplinary input that is needed when managing these growing children who are on TKIs. Most would monitor these children in the clinic itself, and some, about 45%, would request special investigations to monitor organ function, for example, endocrine, growth, bone health, fertility, puberty, and all those things. And very few, only 5 respondents would refer their patients to specialized services for monitoring, for example, an endocrinology clinic. And no formal monitoring was possible in the case of 2 respondents. We also asked whether anyone was, trying to stop TKIs in their patients. 50% had no plans of stopping TKIs in the pediatric CML population that they treat in near future, whereas it was quite heartening to see that 25% of the respondents are probably already started stopping TKIs for children. I assume that these are the adult hematologists treating pediatric CML who, based on the adult experience, were stopping TKIs in children. The last question of the survey was an open-ended question and actually had elicited quite a lot of interesting statements from these respondents, ranging from issues that the patients face while getting treated for pediatric CML, including paying from their own pocket, traveling long distances to come and access TKIs, becoming non-compliant when they start feeling well, to lack of proper guideline that would guide these physicians when managing children with CML in their setting. Many respondents also mentioned about lack of training and experience in pediatricians and pediatric hematologists about managing CML. Consequently, a good number of patients get treated by the adult hematologists. So after going through the results from this survey, we actually summarized the concerns in managing pediatric CML in the low-middle income countries. Regarding patient factor, delayed presentation, diagnosis was common, and historically in the literature, we have seen higher proportion of advanced phases of CML from the LMIC countries. Compliance to treatment is of course an issue in the high income countries as well, but in the low income countries, this stems from lack of access to TKIs, long distances travel to collect supply of medicines, as well as out-of-pocket expenditure in doing so. Loss to follow-up is also a problem, as our second case highlighted, the case that we discussed initially. The second case did highlight about loss to follow-up. And of course, financial toxicity for the patients and families who were self-funding their treatment and follow-ups. When it came to physician-related issues, lack of training and expertise among pediatric specialists was a common problem reported by the respondents. Consequently, many patients get treated by non-pediatric hematologists. And of course, what was an important and often repeated request by these physicians that we interacted with, they say that they really want a setting appropriate guideline to follow when managing pediatric CML. Regarding treatment and investigations, lack of facilities for diagnostics, and of course, monitoring for treatment response, lack of access to all the generations of TKIs due to cost, availability, and of course, issues about generic and innovator brands were also mentioned. There was limited option to manage intolerance and suboptimal response in some of the countries because of lack of any alternative TKIs apart from imatinib. And of course, insufficient resources to handle advanced phases actually plague all the low middle income countries with limited resources for transplant and higher generation TKIs. Follow-up takes a back seat when it comes to low middle income countries due to lack of compliance, adherence to monitoring schedule, as we have discussed previously. Of course, monitoring of late effects don't happen that often in a systematic manner, and transition of care in adulthood is also not seamless in these settings. So when we mentioned about having a setting adapted guideline for managing pediatric CML in the LMICs, we referred back to this important document by the PODC committee of the International Pediatric Oncology Society, CEOP, by Scott Hayward et al., who have actually stratified various hospital facilities based on the infrastructure and resources available. And then they recommend that there should be guideline that would suit all these levels of services. And we know that in pediatric cancer, there are many guidelines in many various pediatric cancers which allude to the need of the low middle income countries. For example, you can see graduated intensity treatment for ALL, for medulloblastoma, for low-grade gliomas, Wilms tumors, and many more. So definitely we need a setting adapted guideline for management of pediatric CML in the low middle income countries. And I'm sure we will take a step forward in this direction very soon. And of course, all the patients should join an international registry just to generate data for future guidelines and management of such patients. Currently, international BFM group runs an international registry led by Professor Frederic Milo from France. It's important to improve awareness in general practitioners, pediatricians regarding early diagnosis and referral. Of course, training of the pediatric manpower in management of pediatric CML is very important. And I would just like to mention about the preceptorship program by ICML Foundation. They are open to accepting pediatric applications. And of course, diagnostics need to improve in a big way. Probably the best way is to collaborate with established labs in the high-income countries. For example, in our hospital, way back, 2.5 decades back, we standardized our RQ-PCR with the help of Professor Andrea Hockes from Germany. And of course, the last point, of course, but not the least, is to ensure steady supply of imatinib and as well as other higher generation TKIs for seamless management of these patients. This is my last slide. I would like to thank Professor Giuseppe Saglio for conceptualizing the pediatric module of the ICML Knowledge Center. Professor Mainov Sutor for being a source of support and co-chairing this module with me. He has kindly gone through the slides before I presented them to you. Dr. Arlene Harris-Buchan and Ms. Nicola Evans from ICML Foundation, who did all the background work of putting everything together in this module. I would also like to profusely thank my colleagues from various low middle income countries who completed the survey that we just presented. I have put their names on the right side of the slide with the countries that they belong from. My colleagues from Tata Memorial Hospital are also to be thanked for the time and help that I got from them in doing all this work. And of course, last but not the least, my patients and their families are also to be thanked for their support. Thank you.